Thank you for being here. My name is Chris Hall. I'm the program manager for the Interprofessional Education Collaborative, and I'm joined today by Wallace Marsh from Pharmacy. And we're just going to very lightly facilitate what I know will be a great conversation at the tables. We have some incredible guests today from the Chronic Pain Support Group, and we'll have them introduce themselves a little bit later. Dr. Marsh, take it away.
Okay, students and faculty, we're very blessed to have community members here today to share their experiences with us. They're in the wonderful blue shirts. So students and faculty, let's give them a round of applause for coming and sharing their time with us. Okay, we're going to start by having these lovely community members go around and introduce themselves and tell us a little bit about themselves.
Hi, I'm Elizabeth. I am an undergrad in the Health, Wellness, and Occupational Studies program on the Biddeford campus. I have a form of autonomic dysfunction, so that brings me here today.
Hi, my name is Judy. I'm from the Chronic Pain Support Group. For the past 35 years, I've suffered from chronic sinusitis and have had multiple surgeries and some nerve damage and chronic pain.
Hi, I'm Christina, and I'm from the Chronic Support Group. I suffer from fibromyalgia, I have TMJ, and I have Raynaud's.
Hi, I'm Dale, and I've had 7 back surgeries. I'm fused my entire lumbar region, and I have a lot of ancillary things going on because of that.
Hi, I'm John, obviously from the support group. I have a complex chronic pain syndrome similar to fibromyalgia caused from excessive injuries requiring surgeries and more injuries afterwards and just plain stupidity.
Hi, I'm Susan Gold. I started the group, the pain support group, in 1993 when I was diagnosed with rheumatoid arthritis. I've had 5 joint replacements, and I'm now in remission. Yay! So thank you for being here.
I'm Jane, and I'm part of the chronic pain support group, and we meet at the house where I live, and so I don't have to go outside. But it's a good group. It has changed over the years. My health history is a challenge. 56 years ago, I had experimental open heart surgery. I had been born with a congenital heart defect, and it wasn't until I was 26 that they thought, okay, let's see if we can fix this, because I had gone into heart failure. And so I have a horizontal incision. The surgery saved my life, but I've lived with collateral damage ever since because some nerves didn't survive the surgery. And now I also have psoriatic arthritis, and Arthur doesn't play nice with my symptoms, my pain issues.
Hi, thank you. My name's Robert Foley. I'm a former Navy SEAL, and I'm here in support of the chronic pain support group that I've been a part of for a number of years. I live with traumatic brain injury, optic nerve damage, PTS, and other system medical things I work with on a day-to-day basis. I have radioactive, high levels of radioactive plutonium and cesium-137 and other man-made isotopes, nice things in my system, in my bones, in my brain. So it's a pleasure to be here to talk to you about chronic pain.
Hi, I'm Lindsay. I'm a third-year pharmacy student here. I suffer from chronic migraines with aura, and I have benign essential tremor.
best for last, right? Ernie Merritt, I facilitate the group. Took over about almost 10 years ago from Sue Gold. Again, it's a peer support group. We come and it's like a family after a while. We talk about how we get through the day, what tools that we found, coping skills, you know, talk about similarities, different challenges in life. I've had 4 back surgeries and chronic back pain, narcolepsy, migraines, arthritis. That's enough. But thank you.
All right, so students, you've heard that these people have a variety of conditions that has caused their chronic pain. And so can we get you guys to join on to one of the other tables since there's just a couple of people here? And same thing with you guys. Could you join one of the other tables with empty seats? So we have a series of questions for you as students, as panels. I want to remind the community members that like when they're discussing the question amongst themselves, let them talk. I mean, I know your tendency is going to jump in and correct their misunderstandings of something. And trust me, we have it broken into the program that you'll be able to say what it is actually like. But at the tables, we please let the students for at least a couple of minutes discuss what they think are the major challenges of living with chronic pain and how does it impact their patient's life. And then we'll turn it over to the community members at the table to actually say what those challenges truly are and what the impact truly is. Well, the students go ahead and discuss what you think those challenges and impacts are. And of course, since this is an IPEC event, bring in your various disciplines about how you think your discipline could help with that situation. So students, give yourselves about 5 to 10 minutes to discuss the question of what are the major challenges of living with chronic pain and how does it impact your life. And then we'll let the community members at your table then chime in with what their true experiences are and the true impacts have been.
Great turn. Instead of just the medications, focusing on other aspects of life, like if it's the pain just making you really anxious or depressed about other aspects to get through, we have to focus on that too, not just the pain.
Just like limiting in what you can do physically, like imagine being in a ton of pain, I wouldn't want to be up and going to the gym or exercising or coming to class sometimes, I'm sure. Studying class, I'm sure. Pretty hindering in that.
Like when I was younger, he was able to do a little bit more than my younger brother, who wasn't able to do as much. So I think just having me
I had a really good description last year about like the spoons. Like just imagine you have like 6 spoons and take away like 3 of them. That's how many like you're able to do energy now. I thought that was kind of exemplified how it, to me at least.
Well, I have a clinician's viewpoint because part of my practice, I'm a social worker, and part of my practice was involved with both children living with chronic pain and life-affecting illnesses, as well as parents affected by various forms of pain and and the impact on families. And some of the things that, of course, you know, as a behavioral health person, I'm going to see parts of people that they don't often represent to the whole world, because they're very private and personal. But a couple of things that over the years I discovered as initially were surprising and now are just what I understand is shame that comes up in often not being able to do or feeling less than some of your peers, some of your friends. And I saw this more with younger, with the adolescents or younger kids. Stigma, because both of you are incredibly good looking, you look healthy, everybody, so people assume that you're fine, right? And so that sort of dual part of the part of you that's on the public side and then the part of you that's on the private side, that there's often a really disconnect between those two. And then there's stigma attached from people saying, well, Sue looks great, I don't understand why she can't, whatever. I think those two things are critically important to raise, because when you don't live with chronic pain or love someone with chronic pain, it's very easy to get judgy about it and to minimize the impact that it has on a person's life and their self-worth. And I'm putting that out there. You can say that's totally not true, but it's something I don't think is talked about enough. And for the younger people, feeling like they're not part of the scene, feeling like watching, healthy, able-bodied friends be able to go do this and this and this and this, and either they do it and then suffer afterwards, or they don't do it and feel isolated. So I think it's a real public health issue, thinking about it from a broader perspective. For me, there were the two major challenges. One is exactly what Shelley was talking about. And that's why I started the pain support group in the first place, is because no one understood, including my healthcare professionals, what I was going through. And I became very angry because people weren't listening to me. They were discounting what I was saying. I was unable to sleep more than 2 hours at a time because the pain in my shoulder was so great. I had not been diagnosed. My doctor was saying I was just getting older. I was 40. He told me that my shoulder hurt just like his shoulder hurt when he played ball with his son. I was not being listened to. I was not being taken seriously. With chronic pain is a different beast from another kind of disease or disorder or illness, because it doesn't show. And I always looked good. I did not feel good. And we talked about that at the chronic pain group, that maybe we should have a big P stamped on our shoulder, on our forehead, so people would know that we were in chronic pain. It wasn't something that showed to other people. And that's why I felt it was so essential to my well-being to have a chronic pain group, because when I went to that group, the first meeting, I was with people who knew exactly what I was talking about. I didn't have to justify why I couldn't go someplace or why I had to cancel. They knew exactly what I was going to do. The other challenge for me was to accept that I was going to have to live with chronic pain probably for the rest of my life. I am in remission now, but I still have vestiges. I have a rotator cuff that's shot that nothing can be done for. I have, as I said, I've had five joint replacements, and they'll probably have to be replaced again. I hope I last that long. I hope I last that long to make that required. But it was a long journey before I accepted that that's what I was going to be like. That's my life.
and I better make the most of it instead of waiting around for somebody to stop pain and cure me. I wanted that to happen, and that's always a good goal to have, but I wasn't going to waste the rest of my life waiting for that to happen. I needed to live my life and find value in what I could do, and so that was a second major challenge, is getting to that point.
Yeah, I think that's real important because each as an individual, once we get a diagnosis, it isn't like a broken leg that it's gonna get fixed. And there's a lot of emotional garbage that goes with that because I don't do change well, and they're necessitated various changes. I don't like to disappoint people, but if I say to them, oh, I'm not sure I can do this, it's like, well, why not? Well, it depends on the weather. It depends on how my body is feeling. Well, why does that make a difference? And and early on I found that a lot of the people in various healthcare professions didn't grasp that it's going to be forever. And it was more emphasis on well, if you just go to this, or if you just do PT, or if you do OT, we can teach you how to get the utensils that will make it so you can cook a meal. But sometimes some of the programs were so structured that you would come into it, okay, you've got chronic pain, this is what we're going to do. And everybody that was in that group was doing the same thing. And I've done an incredible number of different physical therapy, a little bit of occupational therapy, where I walked away from it disappointed. I didn't get what I needed. Right now, at 82, I'm back doing PT. But the therapist I'm working with spent quite a little time the first, and she said, I know why your doctor has sent you here, but what are your goals for being here? And my doctor had sent me there because I had balance issues, and I fell on the stairs, and I said to my doctor, but I didn't go down on the floor. She said, that's all right, it's considered a fall. And so that was the diagnosis, that something was going on in my body, whether it was the arthritis, I'm on a biologic, I give myself an injection every week, or whether it was just, hey, you're getting old. But I needed to have the therapist understand and work with me. And now it's very much individual. And I had said, I know I don't do exercise well. And no matter what you teach me, and you say to me, now you can do this at home, I'll do it for probably a week or 10 days, and then life will get in the way. And by the time I go back to it, it's like I forgot how I was supposed to do this, or what I was going to gain from it. And so we started out very much using the tools in the gym. When I was there on Monday, she said, okay, we're going to work in a different corner of the gym. And she took me over to an area that was set up like my kitchen. A stove, refrigerator, and a counter. She said, now instead of hanging on to this and doing the exercise, you're going to put your fingers on the countertop, and that's going to be a little bit of support. But I want to know what your feet are doing. And you can become aware of what you need to accomplish. And you don't have to say, okay, I'm going to do half an hour of exercises every day. You can do little ones along. Sometimes it was just simply saying, she had me sit down, and then she said, okay, can you stand up for me? And walking around. Where's the arms? What can
Okay,
I
it
get
sounds-
a hold of? I need a boost.
Sounds like there's some good
And
discussions
so
going on.
working
2-minute
with
warning,
her,
2-minute warning, and then we'll share out with the group. So
Okay.
2-minute warning.
Now, cross your hands. Steady your feet. And it's going to take you a little while, but get to the point where you can stand up out of that chair without having to hang on. And I'm making progress. And that was so important because so many of the programs are, okay, this is your diagnosis, this is what we're going to do, and this will fix it. And sometimes we can't fix it, but we can make it so we can have a quality of life.
So at first the referrals to OT and PT didn't help because it wasn't individual?
It wasn't individual.
So you would say it's helping now, individual?
Yeah, this is strictly PT. I had the OT.
Yes. I think they're gonna have us like report out.
Oh, yeah.
I had to have some surgery that didn't work out because the surgeon refused to listen to me when I said, I have psoriatic arthritis, I'm on a biologic, I'm immune compromised. I didn't need to know that. We're going to do gallbladder surgery. And I ended up with a significant problem with a bacterial infection, and I lost a whole summer in and out, hospital, go to rehab, no, you're going to go back here. And there wasn't that listening and so from that learning experience, when another issue came up, and they were going to take me right from the emergency room to surgery, no, I need to go back and switch the line with care to Ernie's table.
Okay.
Before we make any decisions, let's go to a specialist. And I listened to him. And I said, we're going to watch this because I'm compromised from anesthesia. I have a heart disease. So the outcome of that was.
Okay, if we can bring the groups back together. Now we want to have some reporting out from the groups. And so we'll start on this side and work our way around. So would a student from this table please describe to me what you thought was the most interesting thing that you learned about from your community members' experience?
We were, oh, it is? Okay. We were just talking about how hard it is to describe pain to a practitioner and how dynamic it is. It's never the same. And just how subjective pain is, and asking a patient how their pain is on a scale of 1 to 10 is not an effective way to learn about the patient's pain.
All right, so someone over here, what was the most interesting, important thing you learned?
Oh, so I had made a comment that the providers might always not be able to associate with suffering from chronic pain, but then I realized that I said suffering and I should be saying it more of like living with. I don't know.
Is it just really right?
So I had said that providers might not be able to associate with suffering from chronic pain, but then suffering is kind of like a negative demeanor, so you'd want to be more about like living with chronic pain.
Okay, and one of the students from back here at the back table, what was the most interesting thing you learned?
We just really talked about how each treatment plan really just needs to be individualized for each patient. You have to consider all sorts of different avenues for every single one.
Now I'll mix it up, back up the row. So one of the students here talk about what was the most surprising thing you heard?
I wouldn't say it's necessarily surprising, but we were mainly talking about stigmas. After someone says that they have chronic pain, how people in our future fields will view that patient, and then how some of it has gotten better, except for working with veterans. I guess some of the stigmas are still pretty strong.
Same question for this table.
I'd say one of the most surprising things that I heard was that a lot of, surprising but not surprising, is that a lot of the providers they interacted with, A, didn't believe them when they told them that they had chronic pain, and B, like they didn't take like an individualized approach. So that's why the treatment wasn't effective for them, because it wasn't individualized to their wants and needs.
I think the big thing that we discussed was the totality of chronic pain, the way that it sort of overlays or undergirds everything in your daily life, the decisions you make, the way you interact, the people that you're able to do things with, and really having a consideration as a provider or a clinician of what that totality means to the individual, and then looking at ways to try and compensate and figure out, like, given that, what can still be done.
Well, based on the responses we got, it sounds like some of the groups have already ventured into question 2, but you can further the discussion of that. Then we would like the tables to bring up the topic of what matters most to your patient when seeking treatment for chronic pain. So take a few minutes to discuss that at your tables.
Oh, are we supposed to first say what we think and then do? Okay. I'd say just to increase like quality of life and whatnot for the client, so that they can do the things that they need and want to do. But I don't know, that's what I would think would be to matter most, is getting back to those things that they need.
Affecting their wishes, like Haley was saying, not everyone wants to be on opioids. Most people don't nowadays, so just kind of not pushing that and look for alternative ways to kind of cope with the pain. Just being understood, like believe, is one of the most important issues. And then be like, well, it's bad, or it's not like fibromyalgia, like there's nothing like really great.
Probably like to like get education about your diagnosis so you can better understand it too. I think that would probably be really important for them to like understand what's going on.
Well, I can really look at it from like the medication aspect of things.
Saying this as though it's true, but waiting for the experts. But I think balancing that sense of the whole person as, you are not just your pain, and I need to understand your pain. And so I think it puts providers in kind of a interesting conundrum, and especially now given that you have like 12 seconds to even meet with a client. Yeah. But I think, to me, that's, again, what I've learned from the people I've worked with, is that it's like sometimes you want to lead, and sometimes you want to lead, and sometimes there's that back and forthness. And it's a skill, I think, your OT, your PA, that in pharmacy, social work, that it's a skill that all of us need to know how to do, is to see the person first, and then to really, really do our best to understand and be empathic, but also be professional and smart. It's hard. It's hard stuff to do. So.
I think one thing that, in a little bit of the discussion surprised me, but it's been my experience that that's what happens, that we tend to compartmentalize. So, okay, we have to be open to the fact that whatever is producing the chronic pain, whether it was an industrial injury or whatever, arthritis, or some of these that aren't even named, they all bring along some cousins with them. And that we can't just say, okay, you're here, we're going to treat arthritis. But maybe it's the medication you're on that is legitimate for the arthritis. But what does it do about something else? And being open. I had one doctor at one point who said, well, what's your pain level? And then he looked at me and said, and I don't want your general pain level. I just want the pain level for where I did the surgery.
Okay.
And I wanted to say, go away, I don't ever want to see you again.
I bet there were some other words.
Yeah. Well, my mama taught me I should always be like a lady. Sometimes in a rush of things, we get caught up with, well, what else is being affected by.
I think for me, I wasn't believed by my doctor, and so that means for a year and a half I went without
So many batteries almost dying. I did, but
This one is picking up a lot of sound. It's just I turned it off.
yeah.
I think that there's one more in the back too.
Yeah, Julia has one.
Were they being loud or you just?
Should I keep going? Is that oftentimes people dismiss when I go into the doctor's for. So last week I went into the doctor and I said I'm having a lot of pain in my stomach. I don't feel like it's normal because I know my body so well at this point. I know every single thing that I can feel, and I said I don't think it's normal. And they brushed me off last week and said, oh, it's just your POTS, like my condition is called POTS. It's just your POTS, like I wouldn't worry too much about it. So I went in yesterday and I said I really feel like something's wrong. And I had 6 ovarian cysts. So that's just an example of just brushing it off like no big deal, it's just your pain, whatever, move on. But just being so in tune with your body, and you as a patient know better than anybody else. You feel everything. Just being true to your body, and as a professional, listening to patients and realizing that they are the experts on their own body. I think it's huge.
Well, I like the can do, not the can. Because
Yeah,
the can
that's
do
why
there's no positive. So if the doctor tells you stuff like that, the visit's not going to be a good outcome.
Yeah, just being encouraging and not telling you no, helping you get to that point instead of saying you can't.
Yeah. Take a shot. Now, I know a lot of the members, some of them say, the doctor believes me. There's no sign. I mean, one of the members is chronic fatigue syndrome. He walks with pain, and he looks like a drunk. And he doesn't drink a drop. He can't. There's no way. And then have some compassion when, like, he went through some cognitive tests and drained him right down, and he had a hard time walking. And I said, well, I think we should have a wheelchair. Oh, does he need a wheelchair? So just to kind of thinking out of the box, that you just put, he's already got a condition, and you worsen his condition. It might be for a short time, but we still have to get home and rest. I think that should be looked at too, as what you put the patient first. to bring a list of, what's ailing you. Now you gotta go, what's number one and number two? Deal with that, 'cause you got too many. But like she said, everybody's, that's what the professional works. Everybody has a different idea of how to treat. They are a little piece of the pie. And that's, to me, is what a treatment plan needs to be.
Should we go on to the next question?
I think so. The next one.
Yeah. I think we have two. All right. Oh, I'm just gonna treat.
Probably
Just because I wrote on this one, sorry.
How would you guys help your patient cope with chronic pain?
I can start, just to give everyone time to talk. Or I think, so with OT, we would use CBT into our practice. We would use coping mechanisms such as mindfulness. We would do things with like sleep routines, making sure that people have as much sleep as they can, because that's so restorative and helpful for the body and mind. Stress reduction techniques obviously would be what the individual feels comfortable trying and wants to try, because meditation can be a little hoity-toity sometimes. I enjoy it, but it might not be someone else's cup of tea, and just working with the patient to find out what it is they're interested in, or complementary and alternative medicines, like what, and being pragmatic about that, like what is accessible to you, like even collaborating maybe with social work, what are the resources in your area, and just kind of going about it in that way.
That's good. Be one of those times when you gotta know your patient, because myself and probably Elizabeth, I can't meditate. I gotta sleep. And meditation per se is, it's before you go to sleep. Well, it doesn't take long. You get to REM sleep 5 minutes by bed. So meditation is really short. Close my eyes, I'm done. How about the PA side? What do you think?
I think a lot of what we can offer has to tend to be out to referral. I could be wrong. A lot of what we're focused on is okay, so if we can't, how do I word this?
I don't know. Should I start? Try? Well, I'm just thinking of how I would approach this if I had a patient coming in. Well, first of all, I'd probably try to get a really thorough history and get a really good idea of what that patient's day-to-day life is, and maybe try to uncover any maybe psych things that may be going on, on the mental or emotional level that could be contributing to this, and just try to focus on get a good story and focus on any factors in their life that may be contributing to it first, and address those, refer if I need to. And then from my end specifically, it would probably be mostly pharmacological treatment, prescribing, starting with the OTC meds and then going from there.
I want to add something.
Yeah.
The approach that you use, you got to be very careful with something like me.
Yeah.
Because if you start with a therapy or your daily living or something like that, they're going to think that you're thinking it's all in their head.
Okay.
So it's got to be in there. I definitely like to plug into therapy, but it's got to be well said, because the patient might take it.
Yeah, that's just something I would be thinking about while I'm just getting their story and an idea of what their day-to-day life is. And then just based on that story, just probably doing a lot of referrals.
Maybe if you could ask some questions and pull it out.
Yeah, that's what we're mostly trained to do is ask a lot of questions.
All of us are different in chronic pain, but that is very strong with making sure the doctor knows that I am chronic pain.
Yeah. And then there'd probably be a lot of research on my end as
Okay,
well.
2-minute warning, 2-minute warning.
There's a lot of homeopathic things that are starting to come up on their eyes that are used to address chronic pain, which I haven't been trained in, but I'd probably do a lot of research and see if I can
Well, and
get them
for myself,
to try any of that.
we're all looking for alternatives. Out of the box or not,
Yeah.
we need something. So maybe if there's like literature or something during the visit you can give some old reading or something.
Yeah.
Kind of like make me think you care. There's got to be something positive out of that. You're gonna do for it.
I think the biggest thing that we can do is definitely validate your pain and give you the reassurance that we know that you're in pain. I think that goes a long way, just to feel acknowledged and to feel like always kind of presenting what their options are for treatment, whether that be alternative like acupuncture or something, and just finding out what the patient is interested in, not just throwing out like all these different possibilities, but see what they're interested in, what they've done before, and go from there.
Yeah, just being the patient's advocate pretty much, like
Well,
rooting
yeah,
for
if you
them.
came in with an open ear of listening to the patient, like you just said, so what has worked for you in the past? What have you heard of that you would like to try? And then you can go back with some information on other patients that benefit from those techniques.
Yeah, did you guys want to talk about it?
What's that?
Did you guys want to talk?
Well, I'm gonna wait until
What number is supposed
he
to
does it. Yeah, I just
Run 3, right?
before I tell you how I cope with my symptoms, I just kind of wanted to hear how you guys think that how would I possibly cope with something like this?
Your condition.
Yeah, I'm just curious to see like what you guys would think of how I
Probably enroll in UNE.
Enroll into a great profession.
Yeah. Well, yeah.
I'm just curious as to like what you think I should do. As you guys are so educated and you're like you're gonna be, my doctors and therapists and things like that. So I'm just curious as to think like what you guys think off the bat of how to help me, and then I'll tell you what I actually do.
So you said that sometimes things turn into like a fog.
Okay, if we could come back together, we'll do some reporting out at the tables. And this time what we would like for the students to do is report out what they heard from their patient about what matters most to them. So we're interested in, did you hear your community members appropriately, and can you respond back with what was the most important matter to them?
We talked about a lot of things, so I think coming back, this is similar to what I said a minute ago, but just working with the patient in their totality. I mean, there are so many different factors and things that can be going on, from the actual pain, how that pain is operating in the person's physical context, their environment, their relationships, that some of the shortcuts that we're used to, you walk in to see a new person, they're like, all right, what's your pain on a scale of 1 to 10? And you're like, well, it's a little more, you can't necessarily answer that with chronic pain because there's so many factors, you can't narrow it down. So you were talking about a pharmacist who's really, really good about going through everything when you have a medication change, the good relationship with a primary care physician that you've had for an extended period of time, those like long-term caring, spending extra time getting to know you and how this is manifesting for you. It sounded like you were saying that those were probably the most helpful relationships and characteristics you've had. So.
We kind of talked about how physicians and therapists sometimes may not ask what is most important to the client or the patient, and just kind of really getting down to that root, finding what's important to them and what they may want to do. But I think just finding out what's important, and it may not be something that they can go back to, but finding something that's similar to that activity or that occupation that they used to like to do, that still gives them that same feeling of joy.
Someone from this table?
So this is more in terms of after already having a diagnosis. I think it's important for providers to keep an open mind if the same patient comes back with a different complaint, because oftentimes it can be easy for the provider to kind of chalk up your new complaint as to being an exacerbation of something you've already been diagnosed with. But in many cases, it could be a whole other problem. So just keeping an open mind and really being thorough with your exam and your history with the patient so that you can properly diagnose possibly an additional diagnosis.
So our person said that she realizes that living with chronic pain, it's not realistic to be completely pain-free sometimes. So she thinks it's most important just that she's like as functional as possible. And as a student, she thinks it's important to go to as many classes as she can and keep going to work. So she just wants the provider to give her functional and an overall well-being.
So I think the biggest point was that everyone's looking for results, and that kind of ties into how to deliver that result, whether it's through a non-traditional type of therapy or, meditation, or just spending time with the patient and listening to their story and try to understand where they're coming from before you even try to prescribe some sort of medication or some sort of treatment. And I think that's pretty powerful, because sometimes we get stuck into the Western type of treatment, and we kind of forget that there's, other ways to go around to do things. So yeah.
And last group.
We talked a lot about how important it is to treat the patient as a whole, and also how important it is to have the patient on their own team, to be the quarterback, so to say, of their own patient care, because we could be pushing one thing when really we're not listening to what they want. So it's important to have them as the quarterback of their own life, kind of, sort of.
All right, for those of the students, I think most of the ones that had class at 1 are probably headed out the door. If you have class at 1, you might want to check your watch and go quietly. But for those of you that are staying and don't have class at 1, move on to the third question, which would be, how would you help your patient cope with their chronic pain? So how would you help your patient cope with their chronic pain?
We did 3, right?
No. Well, I still want to know about how she manages.
Yeah. Okay, so
Yeah, thank you. See? No.
Oh yeah,
Yes,
exercise,
your side, yeah.
diet, yoga,
Talking to a group of people that maybe can relate, or you feel it's easy to talk about some of the things that you struggle with and kind of get a weight off your chest, maybe.
Don't tell us yet, because I want to guess.
I'm not going to tell you.
I'm thinking of like some kind of stimulatory type of medication that could help you to feel like more awake and throughout the day.
Eating
Kind of
chocolate.
balance your hormones. Your neurotransmitters. So
I didn't understand. What were you saying?
I feel like just trying to like balancing out her neurotransmitters to help her give more
okay.
energy throughout the day.
Is it the sympathetic or parasympathetic that is overcharged?
So parasympathetic is rest and digest, so the more relaxation piece. My sympathetic is overused.
Oh,
My
okay.
parasympathetic doesn't engage.
Doesn't engage.
You would have to
Maybe some
compensate
type
for
of.
that.
Like decreasing epinephrine or something.
I'm not familiar with the disease,
No,
so that's
yeah.
that's the problem.
Yeah. So
Yeah.
you
try to keep to like a specific maybe routine, like really try to structure as much as possible. Yeah. Aromatherapy.
Yeah. Yeah, do you want me to tell you?
Yes.
Like I'm running out of things.
Yeah, so I have a really strict daily routine. So I have a sleep schedule. I cannot miss a day of working out. So at least an hour of high impact cardio to get my heart going, get that oxygen out to my brain, and strength training as well. I go to cognitive therapy, yoga and meditation. I do a lot of EMDR, so hypnosis therapy, like you were saying, to kind of rewire my brain. I'm not on any medication. I take Celexa for anxiety to try to help engage the parasympathetic system, and I do that all mostly on my own, so meditation and relaxation techniques, massage therapy, acupuncture, things like that. What else do I do? Yeah, everything's just natural because there's no cure. I'm special diet. I have really bad intestinal issues, so I have to take time out when I eat and what I eat. Yeah, just like super natural, not any meds or anything.
To have better occupational balance than probably everyone here.
Yeah, yeah, I can't do more than 2 hours of work a day, or else I will see like my health go down. So I have to balance that work, but I try to keep as busy as possible and have I don't like take a day off ever. I have a structured day every single day. If I'm not at school, then I'm working.
What do you mean by working?
So I work for Totality Maine.
For what?
Totality Maine.
Oh.
Yeah, so we raise our own shoes now and make clothes.
Okay.
Yeah. So I manage those stores.
That's cool.
Yeah.
Well, that's funny that you say
That's
that.
cool.
I was thinking of chronic pain is the same thing. You gotta be regimented.
I use your deodorant.
You gotta have the same. If you take a day off, it's like, yeah. And I get migraines, and I finally figured out years and years of having migraines is if I alter my sleeping pattern, I get migraines. If I can't take a nap, then it throws the cycle off. You know, the hour change that we do, that messes me up. I end up with migraine every year. So I'd love to have to change the time. It's the same.
Yeah, that really threw me off.
It does.
I need to change in barometric pressure. I don't know if you noticed when the seasons start to change. If it rains, like today, I woke up with a migraine because it was raining. So if there's a change in the pressure outside, if I get on the airplane, like, forget it.
Another is, and I don't know if this involves eating time. I have to eat it at the same time. I can't skip a meal. It just throws my body out. It's not like I'm going to eat anymore. It's just something happens where I get overtired. And with narcolepsy, I guess it's with, you know, the turkey dinner effect, you know, you just want to lay down and go to sleep. That's me with meals if I eat too much. Eating too much is really not that good. Because I use ice a lot. I can't use anything with narcolepsy, go to sleep. So I have my routine of my recliner with ice. And I get 20 minutes to read the paper, well, usually half an hour with my lunch hour. Not working, but this is my, you know, my life. I take an hour to kind of re-energize. And then to race back on and then do some other activities. Because if I don't, I go to sleep. And that, you know, messes the cycle up. You know, it's a roller coaster living with chronic pain.
Keeping busy is also vital for emotional and mental well-being as well. If you find yourself, I don't know, if you find yourself already, if I'm alone, kind of like not doing anything, alone with my own thoughts, and don't have anybody around me or anything, I start to like get anxiety, thinking about what's going on in my body. I feel like I'm more aware of my need, my sensations in my body, and it starts like a negative spiral. So keeping busy and not having that time where you're like going to your own space, like realizing what's wrong with you, vital for me as well.
Mine, not anxiety, I get depressed.
You're what?
I get depressed. I gotta create something. I gotta have some kind of self-worth. You know, getting up, getting rest and stuff is not enough for me. You know, it has been before, but now it's like this is the best I've been in a long time. Living with my brain. So I always push myself more and more.
Like, so it's just like kind of having everything down to a T. Planning out, it takes a lot to plan out your day.
And that's probably mentally exhausting as well.
Yeah, and that's why you can fall asleep at any time if you have chronic pain because we're so exhausted.
You're exhausted from thinking, okay, how am I going to get through the day? I mean, I try not to eat out because I wear a brace, and it doesn't have to be so to eat that much. I have another brace at home that's a little bigger, I can eat a little more. But that's why it's so nice to have sometimes, yes. I eat this brace off, nothing more. And that's even more. Yeah. So it's hard to tell somebody, oh, let's go and eat. Let's, great. What do you do? When you meet friends, let's go and eat. Yeah, no. And then I have a plate with, aren't you going to eat anymore? You look like you're on a diet. You got to explain yourself. Try not to be rude about it. They're your friends, your only friends you have. So it's hard sometimes.
When I started dating my boyfriend, he loves food and he lives in the North End in Boston and he just wanted to go out all the time. I didn't even want to fully disclose everything. Yeah, because I knew that he would break up with me. I was like, no, my stomach hurts. Or I'd be like, oh, I really I can't eat a lot or gluten free or yeah,
So
it's not something to joke about, but
No. I understand. So is it hard with foods that are harder to digest? Doesn't that give you more of a fire?
Yeah, exactly. But yeah.
Well, it's same. I won't be late supper tonight because I just ate from the race.
Yeah.
Just you don't have that feeling because it's stuff right there. Yeah. I was working when I got married, so it was a different atmosphere. Going to school and trying to, your age, trying to tell other people they have no clue. Chronic pain at any age, but I think at a younger age, it's really hard to tell your friends. You guys, you're living, you're listening to others, but if you're not educated, like a parking pass, like my parking pass, how many times guys have gone to me, oh, you look healthy, why do you have a parking pass?
Yeah.
I'm handicapped.
I have
I lift my shirt and say, I've been wearing this for 18 years, you want to. And that's what it's giving me the strength. My chronic pain is giving me the strength to speak up. Because if I don't speak up, they're not going to know.
Yes.
I feel like it's our job to educate. I didn't think I'd ever have a parking pass. I was the same way. Oh, look at that person that's working fine. They have a handicap. This is in my younger years. Not knowing, not educating. And now, I feel it's our job. We get judged really easy. If I don't have my cane with me, nobody holds the door for me. The kid and I hold the door for them.
Yeah.
And it's a stigma too of male and female. No pain, no gain. I'm done with that.
Do you mind explaining the icing that you do?
The what?
The icing?
Oh.
What is that?
Yeah. Like after this, I'll go home and sit on ice. Sit on ice? What do you mean? It's a chemical, I guess, reaction. You don't have to put it in the fridge. You put it someplace, cold counter or something. It's like a gel pack, and it's got like.
Oh, you have to crack it or something?
Yeah, it's got rocks or something.
Yeah.
It's a chemical reaction.
And it gets
It's
cold.
When it gets thawed out more, it gets softer, and then it gets back There's $50. I think 5 or 6 years. I need another one. It's awesome. It's corrugated, so you can wrap it around your back, put it behind me on my recliner.
Oh, is it like that black thing? And
Yeah.
I had one when I tore my ACL meniscus, so I had it for my knee, and you can wrap it around in different directions.
It doesn't have any, it's self-contained.
Mm-hmm.
It works awesome. I can't, for narcolepsy, I can't take any pain medication. So when I have a hard time, I use Lidocaine for the swelling area. L4, L5S1 is used, it's not the still used. I wear this to keep the weight up. But it works, but it's a crutch. So
All right, 1 minute warning, 1 minute warning.
I used to use heat. I used to, but it would stiffen me up. Even moist heat I'd use. They say, oh, use moist if you can. I went to the hospital one time after the went and went to we went nice hotel and went to my wife said, yeah, I went to the hotel. You know, I was it just, I have no back muscle. It's like jello. Trying to get out. I got out. We were in New Hampshire. And I had to go to the hospital. And I was lying down in the car. Yeah. And then one of our group meetings we went to hot tubs in Scotland. There's a hot tub and sauna and every place in Scotland that sells them. Well, they opened their gala up for us to go in and try everything else. But I tried the sauna. You know, they have different saunas and stuff. I'm like her, I can't be in heat that long. I would go to sleep. So I was in with a couple other members and they were swearing. I'm like, oh, this is good. I gotta get out. Because exhaustion. Does that happen?
I can't be in heat. I can't be like in the sun. I just like being inside.
Okay, this time we'd like to flip it a little. And because the question was how, as a student, would you help your patient cope with their chronic pain? We're going to let the community members say what actually resonated from what the students said to you. What resonated with you?
What was that question?
What was that again? We were kind of talking.
So the students were supposed to be discussing how would you help your patient with chronic pain. So now what resonated with you that they said?
Oh, that's kind of a tough one. I mean, they have the same input. I mean, there's a lot of input that I've gotten in the past, and I'm glad to see that they seem to be picking up on exactly what I've been through, and it's something that they would go after. But we've also kind of been talking about how much different it would be if I was someone that has only been dealing with the chronic pain issue now. You know, say it's only been a year. There's a lot more avenues that I could tap in order to get help. But being that I've been like this for so long, I've kind of been to a lot of them. So there's not too many new things, but at least it's something that can always be reminded. You know, it can refresh and say, all right, did I try that? What kind of effect did it have? So I've gotten good feedback from all of them on that.
A lot of what we talked about concentrated on communication between the patient and the doctor. A lot of times the doctor will sit there at the computer and you're talking and all you see is their fingers moving. They're not giving you any feedback. They're not giving you any emotion. And I've got one doctor, he's a physiatrist, and if I have a test done, he actually turns the computer screen so I can see it, brings up the test, and we go through the test vertebrae by vertebrae by vertebrae. I've got now that I can read these things. I'll point out something and say, oh, is that it? Yep, that's what that is. I'm like, oh, how about that? Oh, yeah, that's what that is too. So, but he's the only one that does that. The only one that I've ever been to that ever really sat down and showed me what was going on.
Well, I think, yeah, I'm not. We had a good discussion about some of the things that can contribute to making accepting chronic pain easier to deal with, coping skills, and just how to make the suggestions to do that more positive. And I think that was important. You add something to this?
So what was the question? We're talking about what we get. I think I am so impressed with the students' willingness to be open to what we have to say, and their
capability, their capacity to see the patient as a person rather than an arm or a leg or a malady. I'm very encouraged that this is valuable information that we're all sharing.
I'll do it. She doesn't want to be in the hot seat. Well, we did a little different. We did kind of like a role play of Elizabeth said, before I tell you how I cope with what I have, my condition, I want you to tell me the treatment plan that you'd give me. And it's amazing because the PAs here, most of them at the table and the OT, they hit it right on the nose. They tailored a treatment plan without really knowing the patient, and they did a very good job.
I think the thing over here that we went over that really resonated the most was that it's not just the appointments and the medical support, it's coping skills, and it's having that, support groups, emotional support, and ways to cope in the moment if you're in pain, and doctors realizing that and helping you find those ways.
I agree with Sue that I'm very heartened and encouraged by the interest in our group of learning what we hope for and how to partner with us to get us some relief. And I know when you get out and practice, it's not as easy, but I have a very strong feeling that things are getting much, much better.
I told my group that I would tell the rest of you that I couldn't remember a darn thing they said to me because I have a traumatic brain injury. Actually, that's not true. They said some pretty profound things and shared some pretty profound things. We seem to be hovering certainly on, as a provider, on that active listening for a reason. Because who here wants to establish trust with your patient? Who needs that? So active listening leads to trust. And in that trust, you can ask that second most important question, which is brought up here to the table on the right, is what's important to the veteran? Now the veteran's going to give you a lot of keys, and they're going to open up doors for you. And you can start to envision possibly a blend. You understand blend? A blend of whether it's prescription, partial prescription, and wellness combined, a blend. And you're getting all that through active listening and establishing trust by listening to that individual saying, answering the question, what's most important to him or her. And then, it's not the doctor having all the responsibility. As a patient, I have a responsibility too. And my responsibility, sitting there, engaging with someone like this, is that I have to live in a positive environment at all times. And when I'm swimming in negativity, I need to find a reason to move away from it and stay in the light and stay positive all day long, every day. And that's my responsibility to myself. So they had some really good suggestions and comments to those things.
All right, we have about 10 minutes left. So at your tables, if you would discuss this next question for about 5 minutes, and then we'll do a wrap up at the end. But it's discuss with your community member what changes they would want to see to the healthcare system that would help them out. What changes to the overall healthcare system would they want to see?
Yeah, I think you guys missed that part.
Okay, I have a good one. I can't wait to see this doctor that I just saw like a couple weeks ago, a month ago. He's a nose, ears, and eyes guy. I get bloody noses really bad. Took a month and a half to get to the guy, PA. And I didn't care, PA, doctor, whatever. Long short, kind of talked to me like I was a kid. I went into the office and saw these little colored pictures and everything. They see more kids than anything else. So the way he talked to me was kind of like, it was okay at the visit. Then I got home thinking about it. That was, I wish, and what I try to do is Dale and I will go to appointments together, bring a friend, because I forget a lot. I think if we had some kind of system where the patient family would go with the chronic pain patient if needed, you know, like sign up or something to that effect. You know, if the doctor's practice, you know, the office manager or whatever had somebody in that office that was available when the patient came in, said, can you take some notes for me so I can bring them home? Because I get the summary report, they've been doing summary reports now. I got a critique in there because I got the summary report. They didn't weigh me. Did they do blood pressure? No. Didn't do anything.
Did they say they did?
Yes. They took it from the last report, from the other doctor, because it was online, you know, on the healthy whatever. My weight was wrong. When I got weighed last time, and I don't care, but, you know, I watch my weight because I know if I'm sick or if I have thyroid, I don't have thyroid, so I take medicine. If my medicine's off, I gain or lose. So I try to keep track. She added 4 pounds. I saw what it said. And then I looked at my charts and said, what the heck? I didn't have my glasses on, but I knew that. I didn't say that.
Yes.
So this doctor just copied and pasted it. And this was a month and a half ago. It's like, okay, no, I haven't. So, and then the report doesn't say anything about what I'm supposed to do now for a month. It's like he gave me stuff to do to get rid of these nosebleeds. It's not on there. So what's the sense of having a summary report if it's not going to summarize it? What was the set?
It was just like an evaluation, and it wasn't like what
It was
he
half
told
an
you.
hour visit too. I mean, he was thorough.
Yeah.
Didn't write anything down. I mean, he did. He was typing and everything.
Yeah, but he didn't give it to you.
But he didn't give it.
It's like a page
you
was missing, and it wasn't. So I think making sure that the summary report is legit. You know, it's formatted to help the patient and help when I go back. I mean, he gave me a piece of paper, 4 different things he wanted me to do. 2 were over-the-counter stuff. 1, you know, change lifestyle and this and that.
But that wasn't put in there.
That was not printed. It was generic stuff that they didn't weigh me, they didn't do blood pressure, nothing. And my medication list. And what he doesn't want me to take for medications because of my nosebleed. And he didn't take into account that I use Advil and Tylenol for pain. You gotta stop taking Advil because it gives you nosebleed. Here again, there's disconnect. I have chronic pain, I have narcolepsy. You know, I have other conditions that he didn't take into account. Allergies. You can't take any allergy medicine either. Allergy season's coming.
Oh, it's here.
You know, my eyes are red, you know, when it happens, and sneezing and itching and stuff. So it's like, okay, I'm doing some of it, but when allergy season comes, I don't know how to do it. I'm going to have to use something. I'm on Totality, you know, year round now. But when I need
We'll take a final minute to put your wrap on your rework of the healthcare system. We'll wrap up after that.
So how am I going to go back and say, okay, you said not to use it. Oh, no, I didn't. You know?
Yeah.
So, and I didn't have anybody else with me either. So I think that, you know, that's
Do you ever, so this is something that I actually just recently started doing at my doctor's office. You can get like online access.
I do.
Do
It
you?
doesn't have anything.
Oh, really? Because I get a copy of all my notes that they write.
I think that's what you were talking about, right?
Yeah.
Okay.
I got a copy coming home.
Okay, but you
and then I went
No,
online.
you didn't check, but there wasn't
There was
anything.
nothing. And then I went to a neurologist and same thing. And I wasn't hooked into their frame because there was like 2 different ones. That took a while.
Yeah, but it also shouldn't be your responsibility to get that information. They should be giving it to you.
Right.
And they're not.
And at that office, they didn't give me a summary report. I checked out without that. And that's what my concern was. Okay, you told me to do this and that. I'm just can't remember. I can't remember.
No, yeah.
You know. And
Especially when they're throwing like 4 different things at you that they want you to do. Like, how are you supposed to be expected to remember to do all of that?
Did he offer to like write it down or anything?
No, just going on a piece of paper, 4 different things. You know, the solution, salt solution.
Yeah.
Some of stuff during the night, you put it on, and no Nasonex and all that. And humidify your room.
All right, we're coming to the end of our time together. And I would encourage you to take the solutions that you cooked up in the last 5 minutes out with you into practice and see if you can make them happen for the benefit of your patients in the future. And I think I would like to take this opportunity again to give a round of applause to our fantastic community members. Thank you for making the time to come today and share your knowledge, your hard-earned knowledge, with our students. Next semester, we'll be starting a service learning type activity with the Chronic Pain Support Group, and so keep your eye out for notices about that, and we'd love to have you participate in that to help that group move forward. Do you yes, I'd be happy to take your picture. Do you have any closing comments you want to make, sir? It's like NPR. You got 2 minutes.
2 minutes. 2 minutes, 1, 2. No, it's amazing just when you brought the mic around to different tables and the different answers we had to these questions. This is what it's all about. This is interacting. Different professions. This is what healthcare needs to be. Everybody has a mind, and we're using it. All professions. That's what makes the healthcare team. We got to make teams up because with chronic pain, multidisciplinary, that's what works. Thank you for having us.
Thanks for coming. Have a great afternoon.